So I'm going to go over some basic concepts about CLL, and then I was asked to cover some specific things. So the watch and wait concept, and some of the new treatments that are maybe coming around the corner. So first of all, what is CLL or SLL? Basically, this is just a malignant disease of B lymphocytes. B lymphocytes are part of your immune system. In CLL, it means the lymphocyte count, the abnormal lymphocyte count in the blood is more than 5,000 per microliter. In SLL, the lymph nodes are enlarged, but your white count is not elevated above that level. But essentially, the two diseases are the same. They are biologically identical, and the treatment is identical. So when you see these two terms in things that you read, that's important to keep in mind. Essentially, what happens in CLL is you accumulate these functionally useless lymphocytes. You accumulate them in your bone marrow, and you accumulate them in your lymph nodes, in your spleen, in your liver. And the reason that they accumulate is they increase their birth rate. They're proliferating at a faster rate than normal. But also, normal cells have a program in them that tells them, when they're not needed, to die. And in CLL, that's perverted, and so as a result, they don't die. They're kind of immortalized, and that helps them accumulate over time. So, why does CLL harm a patient? So the first way that it can harm a patient is bone marrow failure. So the bone marrow is the fatty bit in the middle of your bone. This is a shin bone of an ox. This is the bone marrow in between. So this is the structure of your bone that gives it its strength. This is where we make our blood. That's the blood factory. This here is a normal patient's bone marrow. You can see that there are these nice fat spaces that provide nourishment to the cells that are growing in there. And there's a variety of cells there. This big thing is called a megakaryocyte, which makes platelets, for example. This is an abnormal bone marrow of a patient with CLL. And you can see that there are just this kind of monotonous infiltrate of these small, dense-looking cells. And those are these abnormal lymphocytes. Now, what happens as a result of this, you see there's loss of these normal fat spaces in the bone marrow, and basically what's happened is your blood factory, which is the bone marrow, is piled high with this useless junk, and there's no space for you to make your normal blood cells. The term leukemia basically means white blood. So this is a blood tube that's taken from a patient, and this is actually a normal patient. If you put it in a centrifuge and spin it around really, really, really quickly, it separates it into its components by weight. So down here, this is the red blood cells that carry oxygen. This layer here, this so-called buffy layer, consists of the white cells, and then above there is the platelets that help clot the blood. And all this stuff, the plasma, is the liquid component. It also contains protein and other things, basically the non-cellular component of the blood. In a patient with leukemia, see this dramatic expansion of this white section, and that's all of these abnormal white cells which are circulating around in the blood. What you can also see is, you see there's less of the red component than there is in this normal patient's blood over here, which means this person is anemic. There's less oxygen carrying capacity in the blood, and that can make you feel tired and short of breath and other things. The other way that CLL can harm people is by accumulation of these lymphocytes in lymph nodes, or the so-called lymph glands. And you can see this person has these huge swollen glands in their neck, and in their armpit here and above the collarbone. This can become uncomfortable. The other thing you probably notice about this person is they're very, very thin. They've clearly lost a lot of weight, and that can often happen when you've got an uncontrolled malignant disease. The tumor itself uses up a lot of energy. It can make you feel unwell, so you don't eat normally. And another thing that happens with CLL, and this can happen even in what we call early stage CLL that's not being treated, is that the disease can affect your immune system. So this is a chest X-ray of a person with pneumonia. Pneumonia is probably the most common infection that happens in patients with chronic lymphocytic leukemia. The other thing that everyone with CLL needs to be aware of is the risk of what we call secondary cancers. And by far the most common secondary cancer is skin. So skin cancer is kept under control and prevented from developing by a normal immune system. So when your immune system isn't working, it puts you at increased risk. And if you're a Caucasian and you live in a sunny place like Australia or the southern part of the United States, then and you have CLL, then you're at high risk of skin cancer. The most common ones are these what we call non-melanoma skin cancers. This is a squamous cell and the basal cell carcinoma. This is a melanoma. This is the most dangerous type of skin cancer. I always tell my patients, get a skin check at least once a year, because prevention of this at an early stage is far better than cure. In addition to your immune system not reacting properly to things that it should react to, like infections and the development of other cancers, it can also get hyperactivated against things that it shouldn't. So for example, this is a condition called autoimmune hemolytic anemia, where your body starts making antibodies against your red blood cells and destroying them. A normal looking red blood cell is one like this or one like this. These really dense looking small ones are probably coated in antibodies, and they tend to be removed by the spleen, and patients can get quite anemic. This happens in about 10% of patients at some time during their disease course. So the way that we diagnose CLL generally is by a test called flow cytometry. This is the basic concept. So a cell is shown here. All cells have markers on the surface, which are usually proteins. You can use a thing called an antibody to stick to these markers. And if you put a fluorescent tag on the antibody and then put it through a machine, you can use special detectors to determine what antibodies are stuck to a cell. So you can see CLL cells express abnormal amounts or abnormal proteins and can be distinguished from a normal B cell. So if you hear the term flow cytometry, that's what this is referring to. So one thing that is a common concept that patients with CLL have to grapple with is I get diagnosed with cancer and people tell me, okay, that's fine, but we're not going to do anything about it. We're just going to watch you, this so-called watch and wait concept. And that can be a pretty difficult thing to understand, because so much education goes into telling patients, okay, we've got to diagnose cancer early so we can treat it and cure you. So I'm going to explain what's different about CLL to something like to most solid tumors, which are more common than CLL. So this is what happens in colon cancer, which was one of the most common cancers in our community. You start off with these abnormal cell growths called polyps, and this is what one looks like at a colonoscopy. At this stage, this is probably benign. You can see it's kind of connected by this little stalk to the rest of the bowel. Now, if you find that there, you can put a little loop around it, whip it off, and you're done. The disease is cured. You may never develop cancer. In contrast, if you wait until it turns into a malignant process, when it has the capacity to start invading into the surrounding tissue and through the wall of the bowel, and then potentially to spread to other parts of the body, then you can't cure it anymore with a simple surgical procedure. That's the importance of diagnosing a solid tumor early. When you diagnose it early, you can cut it out, and that's it. Now, CLL is a blood cancer. Blood is everywhere in your body. The cells are circulating around in your blood. They're in the bone marrow. You can't surgically remove a CLL or give a little bit of radiation to one area in the body, and that's it. You're done. So CLL always requires what we call systemic therapy, which goes into your body and goes everywhere. So as a result of that, this concept of you have to be diagnosed early to do well doesn't really exist in CLL. So how do we so-called stage CLL? So it's a little bit different. So in a solid tumor like a colon cancer, the staging has to do with how big the tumor is, how far it's invaded through whatever the organ it's in. Has it spread into local lymph nodes? Has it spread into distant organs, which is called metastasis? So this is an example of how we stage a colon cancer. This one is very superficial. It's just on the surface of the colon. This one here in stage 3 has spread into surrounding lymph nodes. If it's broken out of the colon completely and spread into the liver, that's what's called stage 4. So CLL, we don't stage it like a solid tumor, like I was saying. It's present everywhere in the body. So one of the most common ways we stage it is the so-called RIE staging. Stage 0 is when all you have is an elevated white cell count. Stage 1 means you've got some enlarged lymph nodes. Stage 2 means your liver or your spleen are enlarged. Stage 3 means you're anemic, your hemoglobin is low. And stage 4 means your platelets, which are the things that clot the blood, are low. The importance of this is that as you go down as you go to a more advanced stage, it historically would correlate with a shorter survival. It basically means the closer you are to getting into having problems as a result of the disease. And in the time when there weren't very effective therapies for CLL, this meant people lived for a shorter period of time if they had more advanced stage disease. So how do we determine someone's prognosis in CLL? So the first thing is this so-called RIE stage. There's another staging system called the Binet stage, which they mostly use in Europe. So that tells us how much disease there is. Is the disease causing the patient any harm? The second thing is the disease biology. So not all CLL is the same. You have some patients with CLL will be diagnosed and their CLL is very what we call indolent. It doesn't grow quickly. You can measure it years apart and the white cell count will be similar. Other people's CLL is very different. So they might start here and every 6 months the white cell count is doubling and lymph nodes are growing and other things. Now that's determined by the individual biology of that disease. So things go wrong in the CLL cells. That's why they become a malignant cell. And even though they may look the same under the microscope, genetically they can be very, very different. That's important both in terms of how quickly the disease is going to grow, but also in terms of how likely is it to respond to treatment. And some treatments work really well for some types of CLL, but not so well for other types of CLL. And we can kind of look at the genetics of the disease and have a good idea about those sort of things before treatment. So you've probably heard about some concepts. So you may have heard of something called FISH. FISH is not this attractive-looking creature here. It's a way of looking at the chromosomes of a cell. So these are your chromosomes. So everybody has 46 chromosomes. You inherit you inherit 2 copies of each of chromosome 1 through 22, one from mum and one from dad. And then you have 2 sex chromosomes. So this person's female, they have 2 X chromosomes. A man would have 1 X and 1 Y. So in this case, what you see is this abnormality here. So this patient has a whole extra copy of chromosome 12. That's what we call trisomy 12. That's one of the common abnormalities that we see in chronic lymphocytic leukemia. They've also lost a piece of chromosome 18 here, which has gone and gotten stuck over here onto chromosome 14. That's called a translocation. So this is called a karyotype, where we look at all of the chromosomes. And it can be hard to do in CLL because you need to get the cells to grow in the lab, and sometimes that can be a technical challenge. So FISH is a way of looking for the most common abnormalities in CLL. And what we do is essentially use a fluorescent paint to stick to something of interest. So for example, we look at this middle bit of chromosome 12. So these cells here, you see, this is a normal cell which has 2 copies of chromosome 12 shown by that fluorescent paint. This cell here has 3 copies, so this is abnormal. This is a cell with trisomy 12. So that's what FISH is. It should be widely available, and it helps us determine a patient's prognosis. One thing in particular that we try to identify by FISH is this thing called deletion of 17p. So chromosome 17p, the short arm of chromosome 17, contains some crucial genetic material that is critical for sensing damage to DNA. And responding to that DNA damage either by repairing the cell, or if the DNA can't be repaired, telling the cell to die. So that material is critical for response to chemotherapy. If you have a deletion on chromosome 17p, your disease generally doesn't respond well to chemotherapy. Another thing you may or may not have heard of is this concept called IGHV mutation status. This is something it's not as widely available as FISH, but we've done a lot of work with it at MD Anderson and also other centers around the world as a prognostic marker. Basically, as a normal B lymphocyte has what we call a B cell receptor. This is like a probe that it uses to identify foreign invaders, bacteria, viruses, other things like that. And it goes through this whole process of maturation in a lymph node to eventually become a cell that either produces immune memory or makes these secreted proteins called antibodies. You've probably heard of antibodies. That's what they look like. Part of the process of making a good antibody against an infection is to actually mutate the gene that makes the antibodies so that you make a really tight fit for the infection that you're trying to fight. So if a CLL cell can either arise from one of these cells that's never fought an infection and has an unmutated immunoglobulin gene, or it can arise from one of these cells which has passed through the lymph node, has gone through a process of IGHV mutation, and these ones have much less potential to grow quickly than these ones. So counterintuitively, unmutated IGHV is generally associated with what we call higher risk disease. So I thought I'd kind of discuss with you all some sort of common things that I think are on patients' minds when they come and see me for the first time. Am I going to die? And when? How long am I going to die? Am I going to receive chemotherapy? If I receive chemotherapy, how's it going to affect my ability to function? You know, am I going to lose my hair? Are people going to tell that I'm sick? Am I going to be able to work? Am I going to be able to continue to do all of the things that I do as part of my normal life? Is this disease genetic? Do I, you know, am I family at risk as a result of me having this? And am I going to get a bone marrow biopsy? I've learned after a while that this question here tends to occupy patients' minds during the conversation, so they don't hear the rest of the conversation. So I've started when I meet someone for the first time, say, okay, I'm not going to do a bone marrow biopsy today. Let's get that out of the way, and then we'll go on with the rest of the consultation. So the next thing is, you know, the majority of patients that I see for the first time don't need treatment straight away for the reasons that we'll discuss in a second. So the next question that people have is, you know, I have cancer. Why on earth aren't they doing something to get rid of it? What do you mean you're going to watch me and do nothing? And this can create a huge amount of anxiety. And then the next thing is, well, I have symptoms that I think are related to my CLL. So you say I don't need treatment, but I don't feel well. You know, what can you do to make me feel better? And I see a lot of patients as a second opinion. And I think one thing that I notice is that I think when people go and see a general oncologist who sees a lot of metastatic breast cancer and metastatic lung cancer and really, really sick patients, I think they breathe a sigh of relief when a patient with early stage CLL walks into the door, and because they think, oh, well, that's fine, this person's going to do great. And so I think people often feel like they've been brushed off and that these concerns haven't been addressed. So I spend a lot of time kind of trying to explain the concept of why we do what we do in CLL. So this is where the watch and wait concept comes from. So way back, starting in the 1980s, there were some big, what we call randomized studies done. So the concept of a randomized clinical trial exists to eliminate bias. So what happens is you take a group of patients, you don't know necessarily what the outcome of the clinical trial is going to be. And what you do is you use a computer generation to randomly assign patients to one treatment arm or another treatment arm. And this way, you generally have a well-matched population in each treatment group, so you can directly compare the results. And what was done is that patients were randomized at diagnosis to either get treated immediately with a chemotherapy drug called chlorambucil, or wait until they developed significant disease-related problems and then get treatment with chlorambucil. And what happened was that basically this is what we call a survival curve, and I'll explain how to read one of these in a second, but basically there was absolutely no difference in how long people lived, whether they got treated straight away or whether they waited until they were sick before they got treated. And basically these are the data that underpin the whole of the watch and wait strategy. Now, there are some problems with the data, and the biggest of them is that chlorambucil is a relatively ineffective treatment for CLL. We now have much better treatment options than chlorambucil. So there are some clinical trials that are re-looking at this concept, but it's going to be quite some time before we have an answer as to whether it makes a difference in how long people live. And part of that reason actually is because of how effective our treatments are now, that when people progress to the point of having symptoms and they get treated, they usually respond so well to treatment that it can be hard to show that anything you're doing is improving people's survival. So what do we do during watch and wait? So I spend all my time in watch and wait, other than with education, trying to do preventative medicine. So the problems that patients with CLL who are in the watch and wait phase have relate to immune deficiency, so particularly risk of infection, risk of other cancers. So we talked already about skin cancer screening, but also I make sure people get screened for other cancers like colon cancer, breast cancer, cervical cancer. We vaccinate people, so particularly I make sure people get vaccinated against pneumococcal pneumonia, which is the most common type of pneumonia in the community. And then I talk to people a lot about exercise and cardiovascular health. So increasingly it's becoming understood that in patients who have cancer, if they're fit and healthy, they do better, regardless of the type of cancer they have and the type of treatment that they're receiving. And this is no different for CLL. So the organization that provides treatment recommendations in CLL is known as the IWCLL. There's a meeting every 2 years, and they tend to update recommendations based on new data about every 10 years. So the most recent recommendations came out last year. And basically, they have a list of things that they would say, okay, this is an indication to treat a patient. The first is what I term bone marrow failure. So this is basically you're not making enough blood, you're anemic, or you have low platelets. Another is what we call massive splenomegaly. So your spleen is really big, it's coming a long way down into the abdomen, or it's causing symptoms like pain in the left side of your abdomen, or it's pressing on your stomach and you can't eat enough. You have massive lymph nodes. So They call massive lymph nodes 10 centimeters. Can you imagine having a 10 centimeter mass in your neck and walking around with that before you treat? But they do qualify that to say progressive or symptomatic lymphadenopathy can also be a reason to treat. So we don't kind of wait until generally until it gets to be that big. But and then there are this basket of disease-related symptoms. So we talk about unintentional weight loss of more than 10% of your body weight, fevers, drenching sweats at night, and then this is one that I think probably we see most of all in patients with CLL. So patients often complain of fatigue, which limits their quality of life. Unfortunately, the way that the IWCLL defines fatigue as requiring treatment is this ECOG performance scale of 2. An ECOG performance scale of 2 means the patient is unable to work, and it really is a really low bar. So basically, to be ECOG 2, you just have to be out of bed for more than half of the day. So if you're in bed for more than half the day, that's ECOG 3. So I would probably argue that ECOG 2 is not a great quality of life. It's a pretty low bar for quality of life. So basically, what that all means is you have to be pretty sick before people are going to suggest to you that you should have treatment for your CLL. So I was going to talk about fatigue because I think this is something that really occupies a lot of thought for patients with CLL. I think this is an intensely frustrating symptom for patients and an intensely frustrating symptom for physicians. And that's for several reasons. It can seriously limit your functional capacity and your quality of life, your work, your recreation, your routine daily life. And it can be really severe when you otherwise look completely well. So you could be walking around, you haven't had any treatment, you have all your hair, you haven't got huge lymph nodes, but you feel awful. And it's very hard to explain to other people that this is happening to you and be believed. And I think that sometimes includes the physician that's looking after you. So there's this kind of maybe this perception for some patients that it's kind of in your head, which often is not the case. There's no magic pill for it, unfortunately. So there's some research that's going into this, and I'll show you some of that. But it's not a simple thing to treat. Oftentimes we talk to patients about exercise as a way of managing fatigue. Some patients where it's a real problem, but there really isn't any other indication to treat the CLL, can be prescribed stimulant medications, but they're far from perfect and there's addictive potential. So it tends to be a bit of a last resort. Then there's the option of treating the CLL. And as I explained, in the IWCLL criteria for treatment, you have to be pretty fatigued before you generally decide to be treated. So why does this happen? The main reason probably is these things called cytokines. Cytokines are these little chemical messengers that float around in the blood and act on your immune system. And they're the same chemicals that we make when we have the flu. So oftentimes these symptoms, the same symptoms we have when we're sick with a viral infection, are the symptoms that we have when we have CLL. So one of my senior colleagues at MD Anderson was very interested in this concept, and he ran a clinical trial with a drug called ruxolitinib, which is approved in another type of cancer called myelofibrosis. It dramatically inhibits cytokine production in CLL, and this is what we call a waterfall plot. So just to orient you. The y-axis here represents an improvement in a kind of standardized symptom questionnaire from before treatment to after treatment. And you can see that there's, in some patients, a really quite dramatic improvement in symptoms on ruxolitinib. Doesn't work for everyone, and for some people it's a relatively modest improvement. But certainly in some patients there was quite marked benefit from this treatment. Downside of this is that it doesn't have a major effect on modifying the disease course. You have to take it indefinitely, and it's super expensive. So it's very hard to see a regulatory path to getting this drug approved by regulatory authorities like the TGA, or getting it paid for by payers. But I think the take-home message from this is the fatigue is real, and it's due to a chemical issue in the blood. It's not kind of a psychological problem. So what about actually treating the CLL? So like I said, the reason we don't treat everybody for fatigue is because treating the CLL has potential risk. Every treatment that you take for CLL has potential side effects. Sometimes the treatment may be worse than the disease. But in patients who actually need treatment for other reasons and go on to clinical trials, there have been some analyses done of what happens to a patient's symptoms during treatment. I mean, anecdotally, as a physician, I've seen dramatic symptomatic improvement in patients who get treated with a range of treatments. I don't think this is specific to one treatment, but this is just one study that was done. It was a clinical trial comparing this chemotherapy drug chlorambucil to this new oral targeted agent called Ibrutinib. And you can see this is just a kind of a visual analog scale of symptoms, and you can see people felt a lot better once they were treated and their disease was controlled. And this shows the same thing. So as I said, there has been interest for a while, as we've got better therapies, in changing this watch and wait paradigm. Ideally, what we would like to be able to do is give a patient a very brief duration of a treatment that causes no side effects and gets rid of the disease. That's the holy grail, right? Unfortunately, we don't have that, but there are new therapies being developed, very effective therapies for CLL, and some of these are being tested as what we call early intervention. Most of these early intervention studies make some attempt at trying to identify a group of patients who are likely to need treatment in a reasonably short time frame, because those patients have more to gain from treatment and less to lose. So the Germans did a study with a chemoimmunotherapy regimen called FCR, which you may have heard of. So far, there's been no survival benefit in this study again, compared to just waiting until patients needed treatment. They have an ongoing study, which I'll show you some data from, with Ibrutinib versus no treatment. And then there's a planned study in the Southwest Oncology Group in the United States, which is a big multi-center study, which will compare giving venetoclax and obinutuzumab early versus waiting until traditional treatment criteria are met. So it's important, as I said, we need to try and identify patients who are most likely going to need treatment for their CLL. If I can look at someone and say, well, you're probably not going to need treatment in the next 10 years. If I do something to you that causes major side effects, I've done you a disservice. So this is an important part of the design of all of these studies, is trying to identify most at-risk patients. We can do this in several ways, but this is just an example of what we call a prognostic index. And I'm going to explain to you how to read these Kaplan-Meier plots. So just to orient you, this is what we call a Kaplan-Meier curve. It's a way of plotting time from time zero until what we call an event occurs. In a survival curve, the event is death. So when you look at these curves, each time it drops down, that's been an event. So here a patient has died, here a patient has died, here a patient has died. So at any time where you look here on the x-axis to tell you how long it's been, this is 4 years. You can come across to here and see that many patients are still alive at 4 years. These little dots on the curve are patients who are what we call censored. So they have not yet experienced the event, and the place on the curve represents how long they've been observed for. Does that make sense? Okay. So basically, this prognostic index, it segregates patients out into really low-risk patients who generally have a very favorable long-term survival, all the way through to patients where half of them are dead within 2.5 years. And we do this, and that's why I was explaining that CLL can be so different from patient to patient. And we do this by mostly genomic analysis from the blood, but also some more basic blood tests. So the German study that I mentioned with Ibrutinib compared to no treatment, basically what they do is they take people who are in the intermediate, high, and very high risk groups. So that's this one, and this one. So basically not this group. And they randomize them. So this is this concept of a phase 3 or randomized study to either receive no treatment or to receive Ibrutinib, which is an oral medication that blocks a specific enzyme in the CLL cells. And so this is another Kaplan-Meier curve, but it's important that I explain how this works. This is what we call progression-free survival. So in this case, these events, they're not necessarily death. They're often the disease got worse, what's called disease progression. And in fact, almost all of these are events of the disease getting worse, not the patient dying. Now, this is not a particularly good way of assessing the effectiveness of an early intervention study. I mean, it's not really rocket science to say, well, okay, I've got a patient who's got cancer. I could do nothing, which is this group, or I could give them a highly effective therapy, which is this group. It's not surprising that the disease will get worse faster in the people where you're doing nothing. So this study is designed to actually be able to detect a difference in survival, but it's going to take a long time before we know if that is the case. And there are a lot of other things being done in this study, looking particularly at quality of life outcomes, which I think are important. But at the moment, this is absolutely not prime time. This is ongoing investigation. And this is a similar Kaplan-Meier curve where the event is the time until you receive your next therapy. So I'm going to talk now about, I think people wanted to know what treatments we have available and what I think is kind of exciting and what might be coming around the corner. So this is how I think of the evolution of CLL treatment over time. So this is what we had back in the 70s and 80s. This oral medication, chlorambucil by itself. We then moved to FCR. This is how I think of FCR. It's it's very effective, but it does it does cause some side effects. That's transplant. That's a bone marrow transplant. So in bone marrow transplant, we wipe out everything good and bad in the bone marrow, and then we give you a new bone marrow. So that's quite a dramatic treatment. We're doing very few transplants now for patients with CLL, and that mostly has to do with this next type of treatment, which I call targeted treatment. So this is where we get to be much more precise. So the way chemotherapy works is it causes damage to DNA in your cells. And that's very effective at killing any cell in the body that's dividing quickly and making new DNA. So as well as killing cancer cells, it kills cells like the normal bone marrow, the hair follicles, and cells that line your mouth and your gastrointestinal tract. And it can cause some, in small numbers of patients, some long-term side effects. And then we're moving, so these targeted therapies, in contrast, they generally, the way they work is they find something that's unique or relatively unique about the cancer cell. And they specifically inhibit that process or direct themselves to that process so that they minimize what I sort of term collateral damage. And then there's the science fiction type treatments. So I don't know if any of you have heard of CAR T cells. This is something that is kind of increasingly making the news. Basically, what this means is you can take a patient's T cells, you can engineer them in the lab, to make a new gene entirely that sits on the surface of the cell and acts like a search and destroy probe. So it travels around, finds a cancer cell, kills it, and in the process, they proliferate and grow in your body like a living drug. It's amazing that this can be done, but it is being done. And we got several of these studies ongoing in Houston at the moment. So the traditional treatment for CLL, which really is probably still the treatment that most patients will receive now, basically we divide people up into young and fit or older and unfit. And the reason we do that is not to be discriminating against people. We don't want to cause harm to patients from treatment which is too intensive for what their body can cope with. So patients who are younger, their bone marrow is younger, they can cope with more intensive chemotherapy like this one, FCR. In general, FCR is a more potent treatment at killing CLL cells. We would like to be able to give FCR to everybody, but there's no point in giving it to you if it wipes out all of your normal bone marrow and you need blood transfusions for the next 6 months. So we have to make an assessment of, can you tolerate this treatment? So generally for people who have other medical problems or people who are older than about 65 or 70, we tend to use less intensive chemoimmunotherapy. The one that would be probably most commonly used is this old drug chlorambucil, but we combine it with this fancy new antibody called obinutuzumab. So this is a type of antibody which sticks to the surface of the CLL cells and then activates your immune system to get your immune system to kill the cancer cells. It's very highly effective. So when it's added to chlorambucil, it dramatically increases the effectiveness of the therapy. So those are probably the two most common treatments that would be received today, and both of these are available in Australia on the PBS. So these are data that I present in most of my CLL talks because I think they're quite important to understand. So these are data from the original FCR study, the first FCR study that was ever done, started in 1999 at MD Anderson Cancer Center. These are these Kaplan-Meier curves that I talked to you about. This here is what we call a plateau on the Kaplan-Meier curve. What this means is that you see all these patients are out here, and once they get out here, no one's dropping down. So no one's disease seems to be coming back at that point. So when you see the curve flatten out like a plateau, that means that you can maybe say we might be curing some people from the disease with this treatment. The reason that these two curves are different is this group of CLL patients have a mutated IGHV, which was that thing I was talking about earlier. These ones have an unmutated IGHV. So this type of treatment works better in patients who have a mutated IGHV than an unmutated IGHV. Now, us knowing this doesn't necessarily mean we're able to do anything about it, unfortunately, at least at this stage. But this is something that we're kind of working on in particular, is developing better treatments for this group of patients. And these data have been sort of confirmed in other clinical trials. So another concept I wanted to introduce is this concept of MRD. I don't know if have any of you heard of this concept of MRD. So basically, when you've had chemotherapy, you might have another bone marrow biopsy where they have a look in your bone marrow and they say, okay, so before your bone marrow was full of CLL. After the bone marrow, when we look down the microscope, we can't see any CLL. Does that mean you're cured? No. So the reason that you're not is there is going to be a small amount of CLL that's still there that we can't detect using something as crude as just looking with our eyes down a microscope. And that residual small number of CLL cells is what we call minimal residual disease, or MRD. And there are ways of detecting this, particularly most commonly is using a special type of flow cytometry, which was that thing that I talked about earlier, where we get antibodies to stick to the surface proteins on the cells, and it can tell the difference between a normal cell and an abnormal cell. So the importance of this, I mean, again, this is not entirely surprising. Basically, if you have less disease, you'll take longer before the CLL causes you a problem again than if you have more disease. So this is the concept of MRD. These patients are what we call MRD negative, but you can see even MRD negative patients, their disease often comes back. Basically, that just means that the test has limitations in terms of how sensitive it is. It means that but we are developing better, even more highly sensitive minimal residual disease technology that will be able to be about 100 times more sensitive actually than the test that generated those data. So the next question that comes is, okay, so we can identify some groups of patients who have disease biology which is associated with less good outcome after chemoimmunotherapy. So do some of the new treatments that we have maybe overcome this high-risk disease biology? This is a very complicated slide, but bear with me. So there are two critical processes that make CLL cells grow and survive. And one of them is what we call the B-cell receptor signaling. So remember I showed you the CLL cell with the antibody-looking thing on the surface, this thing here? This is the B-cell receptor. What that does is it looks for foreign proteins, which are called antigens. And when these antigens bind, it activates the cell to grow and divide and do things. So that's a normal process for a B cell. In CLL cells, this process is kind of hyperactivated, and they've got active B cell receptor signaling even when there are no infections to fight. And there's this whole series of molecules, enzymes here, that transduce signals from this B cell receptor through to the cell nucleus to tell the cell what to do, to grow and divide and do things. So we can design inhibitors of these enzymes, and that switches off the B cell receptor signaling, and the cells will die. This enzyme BTK has been successfully targeted by a number of drugs, some of which I'll show you some data. This one has also been successfully targeted, this PI3 kinase. And then the second process that can be targeted successfully in CLL is this process of what we call apoptosis. So apoptosis is a normal process where when a cell gets damaged and it can't have its damage repaired, it'll die. If it doesn't die and it persists as a damaged cell and it's still able to divide, that's a critical process in becoming a cancer. So this protein here, BCL2, is a critical protein that stabilizes the membrane of the mitochondrion. Mitochondria are your cell's energy production thing. If the membrane of this gets damaged, your cell will die. It can't make energy, and it will undergo this process of apoptosis. So in CLL, we want apoptosis. The CLL cells, however, they make tons of this protein called BCL2. And because they've got tons of this BCL2 protein, they don't die like a normal cell should. However, we now have this drug called venetoclax, which blocks this BCL2 protein, and the cells can die dramatically after we give this drug. And actually, a lot of the preclinical and clinical development of venetoclax was done right here in Melbourne. So I'm going to show you some clinical data. This was what we call, again, a randomized phase 3 study. This drug, Ibrutinib, is a drug that blocks this BTK enzyme in the CLL cells. And so this study randomized patients to either get Ibrutinib or get this medication chlorambucil. And you can see from these Kaplan-Meier curves, you don't need to be a statistician to see that there's a dramatic difference in how long people are having disease control for when they get the Ibrutinib compared to when they get the chlorambucil. So these data led to the Food and Drug Administration in the US approving Ibrutinib for untreated patients with CLL. We're not quite there to having approval for this drug in Australia. But remember I told you this IGHV mutation status, and I showed you when you get FCR, the big difference in the curves. You can see with Ibrutinib, there's really not a big difference if you're unmutated or mutated. So this is an example of how, as we better understand disease biology and as we better understand get treatments that more accurately target disease biology, we might be able to overcome some of the things that make a disease behave badly. So I told you about the 17p deletion being the worst prognostic factor in CLL. So Ibrutinib has been looked at in patients with 17p deletion, and this is the Kaplan-Meier curve here, this green solid line, for people who have never been treated for CLL before and receive Ibrutinib as their first therapy. And you can see overall there's a very, very good outcome. So at 5 years, 75% of patients still haven't had any evidence of their disease recurring. And that's similar to what you would get with FCR if you have a favorable prognosis type of CLL. And similarly, venetoclax and obinutuzumab has been tested in a big German CLL study group study that also had some Australian centres involved. And you can see that this solid black line is the patients who did have a deletion on chromosome 17. There's still a difference between those who did and those who didn't, but it's smaller than you would expect with chemotherapy treatment. So we're making some progress with these people who have high-risk CLL. In fact, I would say we've made major progress in patients who've had high-risk CLL in the last 5 years. So the next thing this makes us think of is, okay, well, now we've got these drugs that directly target CLL biology. Does this mean we can get away from chemotherapy entirely? And I think for a lot of us, we're hoping that this will be the case. So there are a whole series of studies, randomized studies that have been done mostly in the US and Europe in the last 5 years, trying to determine, can we do better than standard chemotherapy? So this study compared Ibrutinib and rituximab, which is an antibody, to FCR, which is standard chemoimmunotherapy. And you can see the red is the Ibrutinib treated patients and the black is the FCR treated patients. So you can see that the Ibrutinib treated patients are having superior results. That's progression-free survival. So most of these what we call events on the Kaplan-Meier curve are the disease got worse. This is a survival curve. So there's a small but real difference in how long people are living if they got Ibrutinib compared to FCR. But I'd also draw your attention to the fact this curve in the Ibrutinib treated patients is not really a curve. It's just a flat line along the top, and that's what we're hoping to achieve. The Alliance study was a similar study. This was for patients who were older or had other medical problems that meant that they wouldn't be considered suitable for FCR treatment. So they got a slightly less intensive chemoimmunotherapy regimen called BR, which we don't really use much for CLL here in Australia. And they were compared to 2 Ibrutinib-containing regimens. You can see the results with Ibrutinib aren't quite as good in patients that are a little bit older than in the younger patients, but there's still a pretty significant difference compared to BR. And then venetoclax plus obinutuzumab was another study that was compared to chlorambucil obinutuzumab, and we're seeing similar things. So compared to chemoimmunotherapy, it seems like these new drugs probably work better, at least in terms of controlling disease. Although so far in those studies that I showed you, there hasn't been a difference in how long people live for, just disease is controlled for longer. So these are data from a study that we've been running at MD Anderson. So this is young patients who we would normally give FCR to. And in this study, we actually, instead of doing an either-or approach, we added the Ibrutinib in and switched out the rituximab for obinutuzumab, which is a stronger antibody. And you see that we've had really only one patient, unfortunately, had a infection and died from it. But other than that patient, there's been no events so far on this study. So this is more close to what we hope we can achieve. Now, this is not something that you would be able to give to someone, for example, in their 70s. It's too toxic. We hope we can maybe achieve the same thing with combinations of new non-chemotherapy drugs. So I showed you Ibrutinib, I showed you venetoclax. What about if we combine the two of them together? So this is a study that we've done recently, also at MD Anderson. These represent kind of cumulative rates over time. So we treated patients for 2 years of undetectable minimal residual disease in the bone marrow. And these blue lines are what we call complete remission. At 2 years, we now have 80% of patients with undetectable minimal residual disease in the bone marrow. With FCR, you'd expect 40 to 50%, and less in high-risk patients and more in low-risk patients. These were 92% of these patients had high-risk genetic disease, and many of them were over 65 and were able to tolerate this treatment very well. So. And similarly to what I showed you with that chemotherapy plus Ibrutinib study before, very favorable outcomes for the patient. So I guess take-home message from this is, in untreated patients for CLL, I think we're getting closer to the holy grail of being able to have almost nobody, at least over a short period of time, die from their disease or have the disease get worse during treatment. So what about people who've had treatment already? So historically, the prognosis of your disease was very, very strongly linked to how long your remission lasted after your initial treatment. So if you got FCR and your disease comes back within a year, this is your survival curve. It kind of goes straight down, whereas if your remission lasts for more than 6 years, it's much better. And the reason for this is that the treatment that we had after FCR was essentially more FCR. So if it's not working now, giving it to you again is not going to make a lot of difference. But now that we have these new targeted medications, this has completely changed. So this is the first study of Ibrutinib, which is and this is now, we've been following patients out to 90 months here. So these patients had all had a lot of treatment before. So the median number of treatments people had had before was 4, which means so they'd had chemotherapy, then more chemotherapy, then more chemotherapy, then more chemotherapy. So when they started treatment with Ibrutinib, they were really having amazing results with sort of half of the patients more than 4 years of disease control. And then out here, still many patients in remission at 7 years after starting Ibrutinib treatment. And this is a study with venetoclax, which I also showed you before, where we're seeing very high response rates and prolonged progression-free survival in previously treated patients with CLL. So most patients now who have, so now in Australia, patients who have a short remission after FCR, they're eligible to receive PBS supply of either venetoclax, rituximab, or Ibrutinib, which has kind of dramatically improved the results for patients. So in summary, of these recent treatment developments, I would say we've made dramatic improvements for patients recently with these new treatments, both in patients who've previously had no treatment and also in patients who've previously had treatment, including the patients we really needed to improve the outcomes for, which were people who had a short remission after FCR. And overall, I would say we're now seeing excellent outcomes for almost everybody with chronic lymphocytic leukemia. So that's what I had. So I'm happy to take any questions that you may have.
What do they do when they do a bone biopsy?
A bone biopsy? Let me. Oh, you mean how is it actually done? Okay, so it's done. It's done with what we call elbow grease. So if you put your hand on your hips like that and you feel that prominent bone that's just below the skin in the small of your back, to the side of your spine, that's called the posterior superior iliac spine. That's where we put the needle. So basically, there's some local anesthetic that goes in that numbs the surface of the bone, and then they put a needle through the outside of the bone into that soft, fatty bit in the middle, which is the marrow. You attach a syringe, you suck out some of the marrow, and you squirt it on a slide so that you can kind of see all of the cells. But also, they'll take a little piece of the bone, and usually about 2 centimeters long, and then under the mic, and they'll section that so that they can put it also on a slide, and that gives you an idea of the whole architecture of the bone marrow, rather than just the individual cells. No worries.